Thanks everybody for coming tonight. I'm Dr. Sata. I'm an ICU doctor and now a functional medicine doctor. And I ended up getting into functional medicine after practicing full-time in critical care, including all through the pandemic. And when I was treating patients during the pandemic, it just became very apparent that we were waiting until things were way too far gone before we were really trying to intervene. And I was starting to research other ways to support the body's immune system overall. And, and I found that functional medicine was pretty helpful. At the same time, I had a number of colleagues who ended up developing long COVID and long COVID symptoms significant enough that they actually had to leave the practice of medicine. And this was despite really extensive workups in conventional medicine. And so this has been in kind of high in my mindset for the last 3.5 or 4 years. And so I have a lot of thoughts about long COVID. I'll try not to go into too much detail or an excessive level of detail, but I think it's a really interesting topic. And I think there's a lot that we can do. So first of all, this is mostly just for information. I don't want this to be any official medical advice for anyone. I do treat people with long COVID, but I would want to personalize that for anyone. So this is just for medical or for educational purposes. And when we're talking about long COVID, many of you are probably already familiar with this, but essentially the diagnosis is just that you have symptoms that are persistent, and most of the diagnoses say more than 3 months after your initial infection. The CDC actually said 4 weeks, which I think is a little bit short, but we're talking about persistent symptoms that last for quite some time. And now we have patients who have had symptoms for several years. And so I think the concept that this will go away on its own is just not, unfortunately, not the case, or at least not the case for many patients. And when we look at the impact that this is having on society, the Health and Human Services estimated recently that somewhere between 7 and 23 million Americans have long COVID. The CDC put the percentage at 3.4% of adults with long COVID currently. And it was a higher percentage that had it, but just as of right now, it was over 3% of the population. And when you think about what that does for the workforce, this is a huge number of patients who actually have symptoms severe enough that they cannot work. And a couple years ago, Brookings put out an article estimating about 4 million patients out of work because of these types of symptoms. And when we're talking about symptoms, there's a really broad range of symptoms that it can be. So anything from fatigue, dyspnea is just shortness of breath, brain fog, which I think is extremely common, insomnia, so not being able to sleep, changes in taste and smell, arthralgias and myalgias, that's essentially aches and pains in the muscle and in the joints, inflammation of the throat or pharyngitis, headaches, POTS symptoms, which a lot of patients have, where they get lightheaded and the heart rate goes up when they stand up too rapidly. And that can be a problem that the nervous system that controls constriction of the blood vessels isn't working appropriately. We also see patients who have GI issues, different skin manifestations, depression and anxiety, mood issues. So it's a pretty broad spectrum disease syndrome. And I think that means that there are a lot of potential causes. But unfortunately, what a lot of patients experience is that they have all these different causes. And if you have chest palpitations, you see your cardiologist. And if you've got brain fog, you see the neurologist. And if you've got gut issues, you'll see your gastroenterologist or a pulmonologist or an allergist. And you just end up going from one specialist to the next to the next. And in conventional medicine, we really train, you specialize relatively early, and then you kind of stay in your lane and you focus on that one thing. So the cardiologist is really focused primarily on cardiology issues, and they're very unlikely to ask you about your menstrual cycle. And the GI doctor is really not going to ask you about brain fog or And your neurologist is probably not going to ask you about lung symptoms because we think of them as different specialties. But I don't think that's the way things really function in the body. And in functional medicine, the goal is to try to kind of unite that as much as possible. But it takes a lot more time to investigate all these different aspects in a single patient. And one of the challenges to COVID is trying to figure out how to deal with the heterogeneity or the difference in all of the patients. So if you have a room full of people who all get exposed to COVID and a bunch of them come down with COVID and they end up recovering in a week or maybe 2 weeks, and a month from now it was kind of a non-event and they're back to their normal life, that's fine. And then you'll have a handful of patients who end up with persistent symptoms and they have long COVID. And you're trying to figure out, well, what's the difference between the people who got the virus and got better versus the people who got it and didn't clear it? And then it's not just, or I think those patients are not all the same kind of patients, because I think there are a lot of different reasons why patients might not have cleared the virus. And so understanding what's different about all those different patients is requires an awful lot of focus, and there's not really going to be a single answer for that. And when we try to understand why all the differences, why is this so variable in so many different patients, I think it's because there are a lot of potential mechanisms involved in long COVID, and the different mechanisms for different patients may vary. Nature Reviews put out a review article on this last year that's actually a pretty good review, and they described 5 different potential causes associated with long COVID. And one of them is immune dysregulation and the immune system being over responsive or having reactivation of older viruses. So, for example, Epstein-Barr virus is the virus that causes mono, or which is kissing disease. It's really common in teenagers and in college students. And roughly 97% of the population of adults have been exposed to Epstein-Barr virus. So it's not a rare virus. It's in most of our bodies, but after you've had the acute infection, then your immune system fights it off and it essentially goes dormant. And it may be present, but it's not really causing symptoms. Similar things can happen with the virus that causes shingles, where that's the chickenpox virus. It can be in your body for decades, and it doesn't actually cause a shingles flare until something else happens that suppresses the immune system. And now the shingles virus, or the shingles virus flares and you have symptoms. So I think reactivation of viruses that are already in the body is one aspect. We also think about dysregulation of the bacterial populations that are in the GI tract. And this is, people talk about dysbiosis or the gut microbiome. And the microbiome is just the population of bacteria. You're supposed to have a really diverse ecosystem in your GI tract, and a lot of things can end up changing that. And we know with COVID that the COVID virus itself can change as bacterial populations, and they don't necessarily normalize after the virus clears. We also see there's some priming of the immune system. So some people who have autoimmune disease already existing, or they're predisposed to autoimmune disease, may have a flare of that autoimmunity. We also see patients who have more problems with histamine reactions, and histamine is what's released when you have an allergic response. And so people can start to be releasing histamine all the time inappropriately. And we see a lot more histamine responses in COVID patients, and in long COVID patients. Another aspect to this is what's going on in the microvascular system and the endothelial lining. And you have a normal endothelial lining that lines all of the blood vessels, including all the capillaries in your body. And you want that to be a nice, slick, smooth lining so that the blood flows easily through that. And it looks like COVID can start to disrupt that lining, and you have what's called endotheliitis, or inflammation of the lining of the blood vessels, which can lead to more clotting disorders. And I think patients who have a higher risk or genetic risk of clotting or more likely to have complications that are along those lines. We also know it can affect the nervous system. And one of the ways that it can do that is to affect the vagus nerve. And that's the nerve that controls the rest and digest response in the body. That's in comparison to the fight or flight side of things. And many of my patients end up in this sort of chronic hypervigilant response where they're just always on alert. And I think that can contribute to many different chronic illnesses, but certainly long COVID is one of them. These two were not in that original review, but I think they are potentially additional factors that play a role. One of them is mitochondrial dysfunction. And this is when the mitochondria or the powerhouses of the cells aren't producing enough cellular energy, and you start having more symptoms like fatigue, especially the fatigue that patients get where they get really fatigued when they exert themselves and then they crash afterwards. And I think that's just that they have used up more energy than their body has to spend. Another one that I'm starting to look at now that I think is a little bit newer, at least to me on the field, is looking at the impact of hormonal changes. And this really, to me, came to light when I started looking into what kinds of symptoms patients were having that were postmenopausal and perimenopausal symptoms. And I'll go into some diagrams of this a little bit later, but there's a huge overlap between symptoms of long COVID and symptoms of hormonal changes around menopause. And a lot of women, or a much higher rate of long COVID patients are women, and a lot of them are around that age range. So I think it's important to at least investigate that and have that on the radar screen to see if that's one of the contributing factors. And so when I think about this approach where there's like a million different things that might be contributing, that's in comparison to the idea of a magic bullet. And when Alexander Fleming discovered penicillin, it really was a magic bullet. You had patients who would die of childbirth fever where they had sepsis that was caused by a staph infection that got into their bloodstream. It caused multi-organ failure and they could die. And you had a really young person who got this infection and wouldn't survive the hospital. And when they discovered antibiotics and they were able to treat that infection, and then you had women who were recovering from what otherwise would have been certain death, that really changed the way I think medicine was practiced in the US and in a lot of places, because you were trying to find what is the drug, what's the pharmaceutical treatment, what's the magic bullet that's going to fix this. And in COVID, there's a thought of, like, or at least early in the pandemic, let's get a virus or a vaccine, or let's get an antiviral drug that will kill this virus and make it all better for us. And I think we're not going to find that one silver bullet for long COVID, because I think it's just, there are too many factors involved. You don't need to just kill off Staph aureus like you do for an acute infection. For long COVID, you need to deal with, is there persistent virus? How do we unravel all of the changes in physiology and in the immune system that happened as a result of that virus? And trying to figure out a multifactorial approach, I think, is important. So that gets into the idea of complexity and just trying to figure out how many different things do you have to adjust in order to get somebody back to a better state of health. And I show these diagrams, not necessarily because I think this is the answer, but like the one over here is showing the immune system and how all the different types of immune cells interact with each other, and they use all these different cytokines to talk back and forth to each other. And if you manipulate, your T regulatory cells, it's going to have an impact on your TGF beta, and it's going to have an impact on Th2 cells, and everything is connected. In the same way, if you imagine the spider web, anything that you pull on the spider web is going to shift everything else. And I think our bodies are like that as well. The other factor that adds into the complexity is just the fact that the virus mutates and it's a different virus all the time. And so if this is just a kind of a way of mapping out the evolution of the viral strains, but very much you'll have different lineages of viruses that have different virulence factors or like how they affect the body. Originally, most patients were very severely affected from a pulmonary standpoint. They had a lot of respiratory and breathing issues. And some of the later strains in the virus, patients had more GI related issues and diarrhea and abdominal pain. And it's because it's a different virus all the time. And we might use the same word, I tested positive for COVID, but COVID in 2024 is not COVID from 2020, and it's not COVID from 2022. And so when you go back and then you say, well, now someone has long COVID and it's their third infection and they've had 3 different vaccines at all these different times, there's a lot to kind of unwind through that. When you look at conventional research, there's a lot of money being put towards long COVID research, but most of our conventional research model is based on doing a randomized placebo-controlled trial. The idea is that you manipulate one factor and then you look at the patients who received that treatment and the patients who didn't, and what's the difference. And that's nice when you're trying to find a single agent that's going to make a difference. It's harder to apply that model when you're looking at something as complex as long COVID is. That said, there are a lot of studies, and a lot of these are ongoing. I looked this up on clinicaltrials.gov. I think this was probably 2 months ago, and I just pulled out several of them. And there are studies looking at like Paxlovid as an antiviral. Unfortunately, so far that has not been effective. Transcranial stimulation to try to affect some of the brain fog issues, melatonin, cardiopulmonary rehab. This study in the middle, Avabradine, is actually ongoing right now, and they're recruiting in Rockville. And this says Rockville, Virginia. This should be Rockville, Maryland. But they're looking at the drug Avabradine, in particular in association with long COVID patients who have POTS. And that's one of the symptoms where your heart rate races when you stand up. And I think of that as a dysfunction of the nervous system regulation between the brain and the blood vessels. So when the brain senses that you stand up and your blood pressure is lower, you want the blood vessels to constrict down so that all your blood doesn't pool in your feet. You kind of maintain blood flow to your brain. And that regulation involves the nervous system and the autonomic nervous system. So there are a lot of patients who have dysfunction there. And the study in Rockville is looking specifically at treatment to address that. One of my approaches is to try to understand why people have so many different symptoms. And we talked about mechanisms before. Another potential mechanism is just the ACE2 receptor, because this is the receptor that allows the virus to get into the bloodstream, or into the cells, but you have ACE2 receptors in tissues all over your body. You have them on your heart. And is that why people are having chest pain and heart palpitations or irregular heartbeats? You have them in the brain. And is that what's contributing to brain fog or sleep disruption? You have them in the spleen, which is important for immune cell function. And it's the home for a lot of the T cells and B lymphocytes. They're in the blood vessels, and there's a huge component of inflammation in the blood vessels. They're also in the GI tract. And when you damage some of the ACE2 receptors in the GI tract, you can affect the way the body is absorbing nutrients, like amino acids and other approaches. They're also in the ovaries. That's not depicted here, but I am concerned about some of the hormonal issues women have and how much of that may be related to ACE2 receptor damage. But it hits essentially all the tissues in the body. It's not just in the lungs. So when I think about a treatment approach, in my mind, a treatment approach kind of needs to address everything. And so this is just an example, but it may may include things like pacing, which is slowing down how much activity you're trying to do in a day so that you don't exhaust your energy supplies, evaluating mitochondrial function and energy production, figuring out if there are ways to support that with nutrients. The vagus nerve is that rest and digest nerve. There are different ways to address that. I'll talk about nicotine patches in a minute. Acupuncture can be helpful. Hormonal balance. There's a drug called low dose naltrexone, which helps modulate the immune system. So I think you need this really comprehensive approach to be able to deal with a disease that has so many symptoms. Um, and I talked about this in September. I wanted to give you a little bit more of an update this time to talk about some of the hormonal sides of things. And one of the things we see is that women have a much higher rate of long COVID than men do. We know that the ovaries have the same ACE2 receptors that a lot of other tissues do. And there's suspicion that that ACE2 receptor impact on the ovaries may damage the ovaries directly. We also know that the virus increases levels of inflammation, and inflammation has an indirect impact on hormone function. Stress and cortisol levels, which can go up with infection, also feed back to the hormonal system. And a huge number of women who are still menstruating and have COVID and have long COVID notice changes in their menstrual cycle. And I saw papers that ranged everywhere from 16% to 62% of women were reporting changes in their cycle, whether it was the amount of flow or the length of their cycle, the pain associated with their cycle. We know there are people who are having fertility issues around COVID and associated with COVID. There are higher rates of miscarriage, higher rates of complications around childbirth. And many patients who have long COVID notice that their symptoms are worse right before their periods. That same pattern is also seen in patients who had chronic fatigue syndrome, or this ME/CFS, which is chronic fatigue syndrome. It's a very similar syndrome to long COVID. It's chronic fatigue is thought to be potentially related to Epstein-Barr virus. It's a little bit harder to track because so many people have been exposed to Epstein-Barr. You don't really know when you got it. The one advantage from a research standpoint about COVID is that we know when COVID hit the world and when everybody seemed to get exposed to COVID. And so people are very focused on having that virus and then something changed. Whereas we don't have that same awareness around many other circulating viruses like Epstein-Barr or HHV6. But if symptoms are worsening right around the time or a little bit before the menstrual cycle, or before bleeding, you can look at what's happening within the hormones or of a normal cycling woman. And if right here you start at the beginning of your period when women start to bleed and their hormone levels are pretty low, they start to build up. You have a development of a follicle, then you get ovulation. And after ovulation, you see higher levels of progesterone and you see still pretty decent levels of estrogen. And towards the end of the cycle, both of those hormone levels start to come down. And so you have a natural drop in hormones. And many long COVID symptoms seem to get worse as those hormones are dropping. So I think there is a link in hormones. I don't think that's the whole picture, but it's something that certainly we can intervene on. Other clues that says yes, hormones are likely related. There are other viruses where we've seen this pattern before. HIV and hepatitis B and C have all been associated with things like early menopause and changes in menstrual cycles, miscarriage rates. And so the fact that we have yet another virus that causes all these symptoms, I think is just makes sense from a physiologic standpoint. Then if you have a disruption in hormone production at the level of the ovary, and you were already, say, a 46-year-old woman and you got COVID, and you weren't really having menopausal symptoms, but you had kind of borderline hormones, and this just pushed you over the edge, then when you look back and you say, well, what are my symptoms? Is it menopause related, or is it COVID related, or both? And the overlap between those symptoms is really high. So things like respiratory symptoms, brain fog, dizziness, loss of taste and smell, heart palpitations, which is an irregular heartbeat, insomnia, can't sleep, night sweats, changes in the menstrual cycle, difficulty concentrating, joint aches and pains. I have heard all of those complaints from an awful lot of people, both men and women, associated with COVID, but I think looking at them from both standpoints makes sense. Um, this is just more about estrogen. We know estrogen is involved in your immune system response. It decreases the expression of ACE2 receptors. It helps support antibody production. It may mitigate the effects of cytokine storm, which is that really inflammatory reaction that put people in the hospital, because it's typically an anti-inflammatory. And then we think of women who had gotten COVID and were on hormone replacement therapy at the time that they got COVID, actually had lower mortality rates than similar women who weren't on hormone therapy. So that's enough about hormones. One of the other aspects that I think is a really big issue is mitochondrial dysfunction. And I really think about this strongly in the patients who are coming in with symptoms of chronic fatigue, post-exertional malaise. Basically, they feel okay, but if they then do anything, or they have a busy day, or a busy day for them, then they crash, or then they have a lot worse symptoms afterwards. I think that's related to insufficient energy from the cells. Some of the conditions when people describe brain fog, or brain fog that gets worse when they have to do things that are intellectually challenging, whether that's working on a computer for work for several hours, or in a Zoom meeting following a conversation with a lot of people, trying to drive and keep track of everything that's going on around them visually. All of those things are cognitively very difficult tasks. It takes a lot of energy to maintain all of that. And one of the other issues we see with COVID is that it can exhaust your body's antioxidant system, and so you end up with more oxidative stress. And if this is a mitochondria, there are these little kidney bean shaped things in every cell in the body. The mitochondrial membrane is very sensitive to oxidative stress. And because the mitochondria are their own little organisms, or their own organelles, they don't actually have the repair capacity that the rest of your cell membranes have. And so when you damage mitochondria, it's much harder to repair them. And if you overwhelm your antioxidant system and you damage these membranes, then the enzymes that are supposed to function, that are lodged in those membranes, don't work well, and you don't make ATP. This is ATP, or cellular energy. And you can test for this. This is kind of a busy slide, but basically it just shows that there really is biochemistry behind all of this. So this here is the Krebs cycle, or the citric acid cycle, and it's the actual biochemical reaction that's happening within mitochondria. And I promise you don't need to know this, but just know that it exists. It ends up leading to the creation of ATP. And so in order to have adequate ATP, or adequate energy, first you need to be able to take your fats and carbohydrates and proteins, and you need to be able to break them down or to digest them. So you need all of the digestive enzymes to do that. Then you need to be able to successfully absorb those nutrients. And once you can absorb the nutrients, you need all of the enzymes in these reactions to work well. And a lot of enzymes have cofactors. And the way I think of a cofactor is kind of like hemoglobin and iron. So if you have a hemoglobin molecule that's supposed to carry around oxygen, it needs an iron attached to it. And if you don't have iron, it's not going to be able to carry oxygen. And so even if you had the most perfect hemoglobin gene and molecule, and it's exactly perfect, Without that iron, it doesn't work. And in the same way, a lot of enzymes, which are just other proteins, have other cofactors. And they can be some of the B vitamins, lipoic acid, magnesium, iron. There are a ton of different nutrient cofactors. And one of the things, for example, when you want to burn carbohydrates, is you need an enzyme called pyruvate dehydrogenase. That enzyme has cofactors including vitamin B1, B2, B3, B5, and lipoic acid. If you don't have those cofactors, that enzyme's not going to work, and you're going to have trouble efficiently burning carbohydrates. In the same way, along here, there are a lot of individual cofactors. And for example, the enzyme that takes you from isocitrate to alpha ketoglutarate, you need vitamin B1 and magnesium and manganese. And if you don't have those, that enzyme's not going to work. And so I think some people can start to develop a new deficiency in mitochondrial function because they've got nutrients that they're not absorbing well, or they can't repair the damage that happened because of that oxidative stress. The other thing we can see is that, for example, when you burn fats, you break down the fats into fatty acids. And then in order to get them in the cell, there's a shuttle protein called carnitine, which is right here. And you need carnitine to grab the fatty acid, pull it across the cell membrane, dump it off, go get another one and dump it off. And if you don't have enough carnitine and B2, this process does not work. And anything that's impacting mitochondria is going to impact the efficiency of essentially all your tissues. So it'll be like, you know, your brain's not clicking on all cylinders, but neither is your liver, and neither is your heart, and neither are your lungs. And so you may have a lot of different symptoms. And when I have patients who have a symptom picture that fits with this, we can do some specialized testing where you're measuring all these different factors in the urine to see, are the levels building up because they can't get through this cycle efficiently? Do you have fatty acids that are building up because they can't get through the carnitine shuttle to be burned? And so you can get a report like this. And if I see problems on this report, then I can make more specific recommendations as to what nutrients I would recommend adding in order to optimize function of the mitochondria. We can also look at bacterial populations in the GI tract. And we know that patients who have long COVID have a significant shift in the bacterial populations. And so there are a lot of bacteria that where their populations seem to be depleted and to drop after COVID. There are a lot of other species that seem to become overgrown or much more dominant after a COVID infection. And that ecology that's in your gut interacts with the rest of your body in many diverse ways. So there's a discussion about the gut-brain axis and the way that those bacteria communicate through neurotransmitters and through the vagus nerve and through other signaling mechanisms with the brain, and are associated with things like autism and psychiatric mood disorders, neurodegenerative disorders. Parkinson's is in here, Alzheimer's is in here. We know there's relations between the bacteria in the GI tract and the heart. There's gut-skin relations and a lot of inflammation in the skin, psoriasis and eczema. There are a lot of relations with the metabolism and people having more insulin resistance, more difficulty with diabetes, with obesity, that can be related to the way those bacteria break down and process the food that you put in your body. There's also relations with the lungs. And you've got a mucosal lining in your GI tract, but you also have a mucosal lining in your lungs. And so a lot of the same things that interact affect both. And there is some specific stool testing that we do that is primarily PCR testing, same as PCR for COVID. It's just that it's looking for bugs that are supposed to be in the gut, some of which are pathogens, some are normal, healthy bacteria, some I think of kind of like the weeds. And so if somebody's having more GI symptoms, then we can potentially look at this type of an approach. The other thing we know is diet makes a huge difference. And the getting adequate phytonutrients from plants, and generally colorful plants, is important. Having significant protein intake, because you need protein to run, to make your enzymes, to run detoxification systems in the liver, to support healthy muscle and insulin resistance. You need it. You want food that's not inflammatory, so an anti-inflammatory type diet, and that's been very helpful for patients. Um, the vagus nerve I put in here, and I talked about this a little before, that this was that rest and digest nerve, the counterbalance to the fight or flight system. And a lot of patients who have things like a racing heart, or their symptoms are a lot worse when they're under stress, or they feel palpitations, they feel more shortness of breath, they have more GI symptoms. A lot of those can be related, because if you look at the vagus nerve, which goes from the brain, it goes down, goes to the lungs, goes to the esophagus, it goes into the stomach. Indirectly, it innervates the spleen, which affects a lot of the immune system. It goes to all the intestinal organs. And when the regulatory system here is off, then yeah, people have a ton of responses. One thing that I think is interesting is that the nerve here, the vagus nerve, actually communicates using a specific kind of receptor called an acetylcholine receptor. And there's a subclass called a nicotinic acetylcholine receptor. And nicotine is actually something I found to be really helpful for these patients, or for many patients. And the theory about this honestly came from a small paper. This was a case series with only 4 patients in it. And they made the hypothesis that the spike protein can bind to a couple things. We know it binds to ACE2 receptors, but it also seems to bind to these nicotinic acetylcholine receptors that are on the vagus nerve. And if it essentially gums up those receptors, then it screws up the nervous system signaling along that nerve. And so they had the hypothesis that nicotine, the drug, should be able to bind to these receptors more tightly than whatever this viral debris is, whether it's a spike protein or it's just debris or something. And could you use nicotine, the drug, to displace that spike protein and then reset the system? And in their paper, they reported a series of 4 patients who had tried this. And it's a small paper, but in the back, this little ribbon, the red ribbon, is showing when the patient got a nicotine patch. And this is just a 7-day course of a nicotine patch at the lowest dosage in patients who are non-smokers. All of these other ribbons are symptoms. And so in this patient, the orange ribbon was dizziness, and the yellow and green were loss of taste and smell. And they started nicotine, and the patient's symptoms started to improve, and actually continued to improve even after the nicotine was gone. So that by the time you get to day 16, all the symptoms were resolved. This is a similar patient who they followed for a little bit longer. She had a lot more symptoms to start with, did the nicotine patch for a week. And for her, she had this immediate initial response and then a rebound. But then after that rebound, she came off the nicotine patch, and all her symptoms continued to improve. And they continued to get better even for about 3 weeks after she stopped the drug, which I thought was a really interesting result. This I thought was particularly interesting as well. This is a gentleman who ended up taking a higher dose patch, and I don't know if he just had the wrong box or misunderstood the instructions, but he took a 15 milligram patch, which is a relatively high dose nicotine patch for somebody who's a non-smoker. He did it for 1 day, effectively overdosed himself on nicotine, and had a lot of vomiting and diarrhea because it was just way too much nicotine for him. So he did that for 1 day, had side effects, and quit. And afterwards, his symptoms still got better. And so by 2 weeks out from that single day treatment, all his symptoms had resolved. I think that's interesting when you're thinking about the mechanism of how could this drug work. It's I have since started using this with a lot of patients, and we do it very carefully rather than starting it all of a sudden and just continuing it for a week. We do kind of a much slower titration, and we never use it for the full 24 hours a day. But I've had a lot of patients get significant benefit out of this, and it kicks in fast enough that I think that this is clearly part of the picture. It's not the whole picture, and it doesn't work for everyone. But I think it's a very interesting approach. Um, then there's some other studies. Bruce Patterson, some of you may have heard of. He did some interesting work looking at elevated cytokine levels, which are inflammatory markers in the body. And originally, he came up with a um, formula or an algorithm that says if you have the following elevated cytokines, I give you a COVID score of X, and if your COVID score is greater than this much, I think you have long COVID. I'm like, well, that's very nice, but if that doesn't tell me how to treat the patients, then I don't really think that's very helpful. So originally, I didn't know what to do with this, but he has since come up with a trial that looked at 18 patients, and or this was a original case series where they looked at 18 patients that he treated with two different drugs, Maraviroc and Pravastatin, both of which are designed to target some of the abnormal cytokines that he was documenting. And in that trial, he had patients who had improved objective findings of inflammation. So their cytokine levels improved. And then a number of different symptom scores improved. So they did a fatigue score and a cardiac score. This functional score is a neurologic symptom score. The autonomic score would be more like related to POT symptoms. And he had 4 of the 5 symptom scores that he measured all got better. And it was I think his treatment was between 6 and 12 weeks. So it wasn't a really long course. The one thing that did not seem to improve was shortness of breath scores, but it was in a very small population of patients. Right now, this treatment is undergoing like larger clinical trials to see if they can move this forward. But I think this is going to be a really promising area to follow. Low dose naltrexone is another drug that I think is really promising, and it's an immune modulator that helps alter how reactive the immune system is. It's used in a lot of patients who have different inflammatory or autoimmune conditions. And so there are people who use it for ulcerative colitis and Crohn's disease and multiple sclerosis. It's used in fibromyalgia. There's a large range of conditions where this drug has proved to be helpful. And they're starting to look at it with long COVID. And they've seen a good amount of, or some very promising results. Stanford had a long COVID clinic, and in their clinic, they ended up using it on 207 patients. They only had before and after data for about 59 of those patients who had gotten the low dose naltrexone, but they were seeing improvements in fatigue and this post-exertional malaise and sleep scores in the patients who'd received that. A similar study, this was retrospective, so none of these are the randomized placebo-controlled kind of gold standard, but this is the best data that we have right now. Nancy Klimas's group looked at this, and she's a researcher from one of the VAs down in Florida and has been doing chronic fatigue work for, I think, multiple decades. And she started applying her chronic fatigue experience to patients with long COVID. And that included the use of low-dose naltrexone, and it seemed to be helpful. I found another study. There was a pretty small study with 23 patients, but it seemed like the combination of low-dose naltrexone and NAD was helpful for about half of them. So that's an option. One of the other things I look at is amino acids, and this is kind of coming from that fact that we know that the gut is impacted, and when the gut gets impacted, it can impact the way your body absorbs amino acids. And amino acids they're, first of all, the kind of the little subunits that you use to add up to make proteins. And so you need all the amino acids in the body. But tryptophan is one example. It's a single amino acid. But if you see it right here, it's a precursor for serotonin and for melatonin. And serotonin is really important in conditions like depression and anxiety. And melatonin is important for sleep. And in this system, if you have a lot of inflammation, that inflammation can activate another enzyme, which diverts tryptophan down this alternative pathway here. And now you don't have the tryptophan to make your neurotransmitters. And when I see patients who come in with COVID and they have a lot of mood changes and they have sleep disruption, and we know their tryptophan is low because we can check for it, then yeah, there's a lot of objective things I would consider doing to try to intervene on that. Um, this is just more description of what's happening in the lining of the blood vessels. And we know that this seems to get impacted with a lot of patients. When that gets damaged, I think that sets people up for more clotting disorders and microclots. Unfortunately, there's not a great test for microclots, but there are, I think down in Alabama, Jordan Vaughn has been doing some testing in a long COVID clinic. They bought a fluorescence microscopy scope to be able to look at blood samples. And they were definitely seeing patients who had long COVID had a lot more of these little debris and clots and things floating around in their system. The question is, what's the significance of that? And then, do they really need to be on blood thinners? How do you monitor that? Are there other ways of addressing that? And in my mind, I think the most important thing is, how do you heal the lining of the blood vessels so you're not triggering the formation of those clots in the first place? So there's a lot more that I could go into about long COVID, but I know we've been going on for a while. I did participate in a research trial about a year ago that was looking at a more integrative approach to long COVID. And in that trial, we were focused on 5 different drivers of disease. And one was the ACE2 mediated damage of the tissue. We were looking at chronic inflammation, viral persistence, the thought that there's still virus present and that's what's driving things, mitochondrial dysfunction, and gut microbiome disruption. And so that protocol incorporated an anti-inflammatory diet, a number of supplements, and you had supplements that were targeted at the endothelial inflammation, some of the antiviral activity focused on the gut, focused on mitochondrial nutrients, and a lot of anti-inflammatory support. These are some other sort of foundational nutrients. Everybody needs a decent level of vitamin D. You need magnesium in CoQ10 for mitochondrial function. You need adequate fish oil or omega-3 fats to be able to turn off inflammatory signals in the body. And then there were some lifestyle approaches, making sure people were having adequate sleep, trying to pace their energy levels. They weren't crashing all the time, dealing with stress, movement. And that sort of comprehensive approach was actually pretty successful. And it was a 90-day protocol. And they did something called the post-COVID function scale, which really tries to evaluate your COVID symptoms on a scale that only goes from 0 to 4. And 0 is totally normal, no problem whatsoever. And 4 is essentially bedbound. So 1 point on that scale is actually a really big jump on the scale. And in that trial, they went from a baseline of 2.0 to 1.2 in just a 90-day approach. And I think there are things that we've come up with since this trial was done. Like, I wasn't using nicotine patches when we did this. I wasn't using low dose naltrexone. So there are a lot of other things I think we can continue to improve on, but it just shows how a comprehensive approach really can be successful. So when I think about patients and when I work with patients with long COVID, where do I start? And the first part is really to get a very good history of what's going on, to try to understand what was different about them, or what did their history look like at the time they got their COVID infection, to try to understand why did they react so much differently than somebody else who just recovered in a week. Then we look at predisposing risk factors, whether it's toxin exposure or stressors in your life or caretaking responsibilities, other infections, potential genetic risks. So we can understand what's unique. And my sense is that it's not the same thing in every patient. It's going to be different in all these patients. And so you just have to take the time to be able to figure out what is so different. And then depending on what that shows, then we can start to tailor recommendation that says, I'm really worried about, your gut, or I'm really worried about energy production. And therefore, I think we should do the following testing. And we customize that based on the patient. Oops. So when that's essentially a functional medicine approach, it's looking at everything that may be involved and then trying to address as many of those things as we can. Because I believe that the body is fundamentally always trying to heal. And we just need to figure out what are the things that are standing in the way of that. If that's repleting nutrients that were low, if that's fixing gut bacteria, if that's dealing with external stressors, if that's supporting sleep, if that means, dealing with pathogens that are still present or that have been reactivated, you got to look at all of that. And my original training was actually in general surgery. And if you come into the emergency room and you had cut your arm and somebody sutures it back together, that did not heal the wound. All that really did was bring the edges of the tissue back together in close proximity so that then your body can heal it. And your body knits that tissue back together and does the healing essentially from the inside out. And these sutures are just there to provide structure and support until your body can heal on its own. And that's the same way that I think about supporting patients, whether it's long COVID or chronic fatigue or fibromyalgia or any number of chronic illnesses, autoimmune disease. We just need to figure out what support structures do the patients need, put those into place, and then let the body does what it does on its own and let the body heal. So that's it for now. We're going to stop the recording and then I'll take questions and we'll go from there. Thanks.